Hit the subscribe button or visit us at auau.auanet.org.
All right, good afternoon, everyone, and thank you, Dr. Scarpato, for a really fantastic summary of a very complex issue and one that has engendered significant debate among medical oncologists and other providers as well. So we're going to take a little bit of a transition and talk about the role of chemotherapy, treatment sequencing, and future approaches in terms of the management of metastatic castration-resistant prostate cancer. So as has been previously discussed and presented, that we really do have a landscape of treatment options available in prostate cancer. However, cross-resistance is the rule, it's not the exception. So that's where we have to really be thoughtful about how we sequence the different types of therapies and really looking to move across different mechanisms of action in terms of how we manage men with this stage of disease. Now, one of the first trials that I think was really pivotal and probably my favorite publication in 2019 was the CARD trial. So I'd like to spend a little bit of time talking more about the CARD trial and how that impacts our decisions in terms of the therapies we should provide for men with mCRPC. So this particular trial, as mentioned before, enrolled patients who had a short duration of benefit, so less than 12 months of benefit to their AR signaling inhibitor. So if you're on ABI, you progressed within 12 months, ENZA the same. So those patients were offered enrollment on a clinical trial in which they were randomized to receive either cabazitaxel chemotherapy or the alternative AR pathway inhibitor. So if you're on ABI, you were offered enzalutamide. If you're on enzalutamide, you were offered abiraterone. And very importantly, what they found was that cabazitaxel was significantly superior in this clinical context, with a median RPFS rate of 8 months versus 3.7 months for going with a second AR signaling inhibitor. And as you can see, just looking at the Kaplan-Meier curves, that again, so many patients just progressed within the first 3 months on their AR pathway inhibitors, and there is no tail, meaning that, again, very few patients were on an AR pathway inhibitor and had a significant duration of benefit. Now, again, this is also, something to remind you when we think about selection, patient selection. Again, these were patients who had a short duration of benefit from AR pathway inhibitors, and there's more molecular data that we hope will be coming out in the coming years to identify any high-risk genomic features that might also explain the patients who benefited the most from the chemotherapy. Now, similarly, we saw an improvement in overall survival as well. So 13.6 months versus 11 months with the AR signaling inhibitor. Now, again, this was published in 2019. There are other therapies that have been FDA approved since that time, and we'll spend a little more time talking about that. However, one thing I do want to come back to in terms of safety of cabazitaxel, and this was, I think, maybe a surprise to many of us, and when we come back to some of the CHARTED data and the STAMPEDE data comparing docetaxel versus an AR pathway inhibitor, where we saw there was a decrease in quality of life and increased safety signals with the chemotherapy. Actually, in this clinical trial with CARD, is actually nearly identical in terms of serious adverse events. So chemotherapy had a similar frequency rate compared to ABI or enzalutamide. Again, very much a surprise to us. And I think that in many ways it speaks to the morbidities associated with progressive mCRPC. Now, when we also look at adverse events that were associated with death as well, again, actually, it was lower for those patients who received cabazitaxel compared to an AR pathway inhibitor. When we look at other secondary and critical clinical endpoints, that pain response, also chemotherapy with cabazitaxel was significantly better than ABI or ENZA in this clinical context, as well as the probability of no pain progression, meaning that their symptoms were stable or controlled. Also, the chemotherapy was superior. In terms of symptomatic skeletal events, again, chemotherapy was superior compared to looking at ABI or ENZA. So when we look at the median, but also the probability of having no skeletal symptomatic events, also superior for chemotherapy as well. When we look at our FACT-P adjusted mean changes from baseline, in fact, again, and this was very different from what we saw with STAMPEDE, that patients receiving cabazitaxel related, both pain-related and prostate-specific concerns were better with chemotherapy compared to abiraterone or enzalutamide in that second-line setting. Now, this also really, I think, comes back to the significant symptoms and morbidities associated with progressive mCRPC. And when we use a more effective agent to control the cancer, patients feel better. and that the adverse events, the toxicity profile, especially with cabazitaxel dosed at 20 milligrams per meter squared, is much better tolerated. And I will say just very briefly, cabazitaxel was initially FDA approved at 25 milligrams per meter squared. The original phase 1 trial with cabazitaxel recommended a dose of 20 milligrams per meter squared. The decision to use the higher dose for the phase 3 was out of a theoretical concern that patients progressing on previous docetaxel might have some degree of resistance. So they went with a higher dose that was far more toxic, which was why they had to do the Procelica trial demonstrating that 20 milligrams was equivalent in terms of efficacy. So again, at the lower dose, cabazitaxel is a well-tolerated chemotherapy. Now, this next leads us to ask, I think, a number of really critical questions of, are there other factors that might guide our patient selection? And this is really where we come back and think about the molecular drivers of aggressive prostate cancer. Now, we know that there are clinical signatures, clinical features that are very important for us to note. So, for example, patients who have any of the following criteria are ones that have what would be considered poor risk or high risk disease. So visceral lesions, especially liver metastases. Large, bulky lymphadenopathy greater than 5 centimeters, a low PSA in the setting of a very high volume disease, or predominantly lytic rather than blastic bone metastases. These are criteria developed by Dr. Ana Aparicio at MD Anderson and has been validated in multiple clinical studies as being a poor prognosis. This is, for me, very much an indication of if I'm not sure if I should do a biopsy, do a biopsy. These are the clinical features that would guide me towards that type of more invasive procedure to understand the drivers of that cancer. Again, because that can guide me in different directions in terms of what I would do. Now, what else can we find on a biopsy? Now, the first is actually histology. We think traditionally about neuroendocrine prostate cancer, at least in the de novo setting, is extremely rare. Less than 1% of patients present with de novo neuroendocrine or small cell prostate cancer. There's been a host of studies over the last decade, and I'll show you a few of them, that have been able to identify that there is a subset of patients that at the development of progression on an AR pathway inhibitor can have a transition into this type of neuroendocrine or small cell prostate cancer. Now, unfortunately, this is where PSA often fails us. And especially as we'll show you that this can be up to 20% of patients progressing on aburenza can fall into this neuroendocrine setting. There's also some other data that Dr. Andy Armstrong presented coming out of ARCHES that showed that for patients progressing on enzalutamide, that half of patients may not have PSA progression, but they will have radiographic progression. So what's driving a disease that's progressing in the absence of PSA? And the first thing we should think about is neuroendocrine prostate cancer. Now, some of the other kind of classic paradigms, we think about small cell cancers in general, whether that's paraneoplastic syndromes or some other serum markers that, generally speaking, we rarely collect. It's otherwise difficult to detect outside of a tissue biopsy. What do we do with that tissue biopsy once it's been collected? Generally speaking, IHC for expression of chromogranin A or synaptophysin would be the IHC markers that we would look for. We'll show you in just a moment some of the genomic signatures that are also critical. In terms of treatments, very briefly, we treat it like a small cell cancer. So we're looking at chemotherapy combinations, often platinum-based therapies. So whether that's cisplatin and etoposide or carboplatin and cabazitaxel. So we should also consider sending that metastatic biopsy for genetic testing. So what we're looking for is understanding those molecular drivers in not the development of the disease, which you may have done with the initial presentation of metastatic prostate cancer, but now we're trying to understand the evolution of resistance. So what has changed from when they first presented to where they're at today with this very aggressive disease? Now, the first and what we'll get from most of our commercial vendors, whether that's Strata, Foundation Medicine, Caris, Tempus, or others, is looking for specific genomic alterations. Now, there's kind of a hallmark of 3 genomic mutations that we want to consider in terms of very aggressive prostate cancer. That's P53, RB loss, or P10. So any or all of those combinations are associated with inferior survival and strongly associated with neuroendocrine prostate cancer. Now, this was a series done by Dr. Misha Beltran at that time at Cornell, now at Dana-Farber, who evaluated and did genomic profiling and transcriptomics and epigenomic analysis of biopsies from patients with both neuroendocrine and adenocarcinomas. What they found was that, as you can see, that P53 mutations were actually quite similar when we look across both the NEPC and the adeno patients. So when we look at just P53 mutations, you can see them in both. However, we do see more commonly AR mutations in the adenocarcinomas that would drive resistance to AR-targeted therapies, while P53 and RB loss, not always, but more commonly found in neuroendocrine cancers. Now, Dr. Beltran did transcriptional profiling and also was able to identify for the first time that these neuroendocrine prostate cancers, when we look at their transcriptional signatures, that NEPCs have low expression of AR or AR-regulated genes, and their transcriptional signatures are also consistent with a disease not driven by AR signaling. So PSA is not a reliable biomarker to detect NEPC, and especially if you have a patient who comes in with new or progressive pain, in the absence of PSA progression, that really should be the first thing that you're thinking about, is this someone who has NEPC? Now, some other studies looking at the kind of broader landscape of mutations that we can identify in those metastatic biopsies. So this was a series by Robinson et al., published in Cell in 2015, where they did metastatic biopsies of patients with metastatic prostate cancer for broad genomic profiling and transcriptional analysis as well. Now, this included patients with bone, liver, lymph node, and lung metastases. The majority, as you would expect, would be bone metastases. I will say we actually very frequently do bone biopsies and sequencing at our institution through some dedicated effort from our interventional radiologists and our pathologists to eliminate decalcification. We now have about a 90% success rate with bone biopsies for genetic sequencing. So it's absolutely possible. It just requires a team to get the processes in place. Now, the power of what we find, I think, is really critical here. So as an example, when we look at bone biopsies or metastatic biopsies from CRPC, we can see that there's a host of alterations. Now, that includes androgen receptor genomic point mutations, deletions, rearrangements that would drive resistance. So when we think, for example, with the CARD trial, those patients who went on to a second AR pathway inhibitor, it's very easy for us to understand why those patients would not respond if they had mutations in the androgen receptor, which makes up anywhere from 2/3 to 3/4 of patients in that clinical scenario will have mutations in the AR. We can find mutations in other pathways that also drive proliferation, such as PI3 kinase. We heard earlier from Dr. Scarpato about DNA repair pathway mutations, as well as a few others. To delve a little more deeply into those mutations that can occur in the AR, we see that they include hotspot mutations, including T878A, 742C, and 702H. I highlight those specifically because those are in the ligand binding domain, the domain of the AR that is bound by enzalutamide, darolutamide, and apalutamide. So again, clear reasons why those drugs would be less effective. Now, those mutations can also lead to other transcriptional alterations with expression of AR splice variants, which was Dr. Gerard mentioned earlier today, with one of those AR splice variants, ARV7, as one that can be associated with treatment resistance. We heard a little bit before about DNA repair gene alterations, so I won't spend much time talking about those other than to say that generally speaking, if these are truncal or driver mutations, we do expect to see these in patients with metastatic castration-sensitive disease. So whether we see new or acquired alterations in DDR pathways is still under investigation. But again, if you haven't looked for it before, you absolutely need to look for it now. We've already heard today about synthetic lethality and how the use of PARP inhibitors really is absolutely critical in terms of targeting prostate cancers that do have somatic BRCA1/2 mutations, especially if there's both somatic and germline mutations. Those are the patients that make up roughly, we expect on the case series, 5% of patients with metastatic prostate cancer. The durations of benefit and response, it can really be, well, I shouldn't say this, they can be profound. So they really are quite impressive. And that's something that you see here in the clinical trials from Dr. Matteo and Dr. De Bono back in 2015, and ones that we're moving forward here into the PROfound trial that was also discussed earlier. Now, very briefly, as discussed, with the addition of PARP inhibitors, we do see improvements in rPFS. And for patients with BRCA1/2 mutations, or other DDR pathways, we do see improvements in overall survival as well. One thing that I would like to highlight is that ATM, classically defined based on preclinical models as a gene involved with DNA damage repair. Unfortunately, for patients with prostate cancer with ATM mutations, they do not respond to PARP inhibitors. So there's been more data that's continued to emerge, and that's really what we see here in this slide, looking at specific gene alterations, where the vast majority of the benefit was driven with olaparib with BRCA1 and 2 mutations. There's a lot of research trying to understand both the biology, why does ATM mutants have a different profile, or at least response rate, a lower response rate to PARP inhibitors than others. New drugs are being developed targeting specific ATM mutations, so I'm very excited for the future and new drugs being developed for these patients. But I'm very cautious to counsel my patients that ATM mutant prostate cancer has a poor prognosis with a more aggressive disease, but unfortunately one that's less likely to benefit or unlikely to benefit from PARP inhibitors. Now, in terms of combining PARP inhibitors with androgen receptor signaling inhibitors, as you heard, there's a lot of interest and excitement, and some preclinical models, not all, but some suggesting there may be synthetic lethality. I will say one of the other areas that I think is maybe even a little more straightforward is to say that while mutations in BRCA1, 2, and related genes are associated with changes in DNA damage response, that doesn't mean that this is a cancer that's not also driven by an AR-driven proliferative signal. So if there's an opportunity to block the AR while also blocking that DDR mutation, I think that's one of the areas where we can have significant or potentially synergistic activity by blocking dual pathways driving the disease. As mentioned, TALPRO-2, really fascinating in terms of the use of a novel PARP inhibitor that has a different, in terms of how the drug works, is different from other PARP inhibitors. The hazard ratio, especially when we look at RPFS rate, was significant, and whether that holds out in the overall survival data is yet to determine. I think that's going to play a big role because there is, as mentioned before, toxicity associated with PARP inhibitors that is not insignificant. What else can we find when we do genomic mutations? So there's also a rare subset or uncommon subset of patients who have mismatch repair deficiency, high microsatellite instability, or even high tumor mutation burdens. Now, we're probably talking 1% to 2% of patients. This is very uncommon. However, my gosh, if you get that patient in that 1% to 2% and they respond to what is otherwise a very well-tolerated treatment with pembrolizumab that can have very long duration of response, it really is quite inspiring. Andy Armstrong has published on a case series of a patient who had brain metastases. Again, an exceptionally unusual presentation of metastatic prostate cancer, but 3 years out from brain metastatic prostate cancer on single-agent pembrolizumab is very impressive. So while rare, don't miss that opportunity to give that treatment for that patient population. Now, what about theranostic approaches? So the other, again, I think major advance that's happened in the last few years in prostate cancer, and really all solid tumors, is the understanding that there are proteins expressed on the cell surface of cancer cells that are potentially targets, not only for molecular imaging, but also for therapeutic targeting. So this was one of the earlier studies. Again, this was building on our growing body of data using PSMA as a PET agent, but now asking, what if we attach a different radioactive molecule, in this case lutetium, could that also serve as a therapy? So it was really these very impressive findings done. These were some small studies published in 2016 using a PSMA small molecule conjugated to lutetium, showing that when we track patients using these PET images, as you see here in the center, that these are patients that can have, at least initially, very significant responses, both in terms of their disease burden, going out to 3 cycles of therapy, but also in terms of percent change with PSA. So, these were really dramatic waterfall plots in these smaller phase 1 and phase 2 trials. Now, it was these early results that led to the development of a large randomized phase 3 trial of PSMA lutetium, now known as Pluvicto, for patients with progressive PSMA-positive metastatic CRPC. Now, I want to talk a little bit about the eligibility criteria for this for treatment with Pluvicto. So patients were required to have a gallium-68 PSMA PET. There is another PET tracer, Pylarify, that's currently available. The FDA did not allow that or include that in the indication, though the NCCN guidelines, in an effort to make things easier for patients and providers, did include Pylarify as something that can be used for determine eligibility for Pluvicto. Now, in this study, patients, all sites of disease had to be positive for PSMA, and that PSMA positivity was defined as expression higher than background liver PSMA avidity. Patients had to be treated with at least one, but no more than 2 prior taxane chemotherapies, and there are a number of other stratification criteria that were included. So patients were randomized on a 2-to-1 basis to lutetium PSMA with best supportive care versus best supportive care / standard of care, which in this cohort ended up being patients almost exclusively treated with a second androgen receptor signaling inhibitor. So there were a number of issues, however, that came up in the conduct of this trial. The first was that they assessed 1,179 patients. 1,000 patients were considered positive for all of those criteria. So less than 10% of patients were excluded, which was what they were looking for, was a very broad indication. In terms of baseline characteristics, it was relatively well balanced. I point out that a number of patients had prior local therapy, so the percentage of patients, but there were a significant number of patients who initially presented with metastatic disease that enrolled on this trial. In terms of the primary endpoints, they did meet their primary endpoints of overall survival as well as radiographic progression-free survival. This was very controversial, and if you have time, Mary Ellen Taplin from Dana-Farber, Dr. Taplin gave a really fantastic commentary on Pluvicto at the plenary session, that this was another agent that was shown to improve survival. However, the median improvement in overall survival was only 4 months, which was, while exciting as a new therapy, we were frankly expecting much greater based on some of the phase 1, phase 2 data that had been previously presented. One of the other things that was quite surprising, frankly, was that the RPFS rate. So if we look at median RPFS, was 8.7 months for PSMA lutetium versus 3.4 months for patients who were treated with a second AR inhibitor. The control arm was frankly nearly identical to what we saw in the CARD trial. So novel mechanism of action, novel therapy for patients selected based on expression of the target, but we saw median RPFS rates of only 8.7 months. Now, when we look at the PSA waterfall plots, again, similarly, we see that there is, quite profound decreases in PSA, which I think made all of us feel better, at least initially. However, very concerned that patients can progress quite quickly after this therapy. In terms of safety data, and this is what we're spending some time talking about because Pluvicto is not a benign therapy. In terms of adverse events that we saw, Pluvicto was associated with a higher incidence of fatigue, a significantly higher incidence of bone marrow suppression, and that includes leukopenia, anemia found in nearly a third of patients, as well as thrombocytopenia in 17% of patients. And especially in this late stage situation, and I have personally had patients we've treated with Pluvicto who developed thrombocytopenia that did not recover, which meant that they were not eligible for further systemic therapies, especially chemotherapies. Dry mouth is also on this list here as well, occurring in almost 40% of patients. I do want to point out the grading for dry mouth or stomatitis. Grade 1 dry mouth means that you need something to drink to be able to swallow your food. You're uncomfortable, but you can still do it. Grade 2 is it is impossible to swallow food without having some other liquid substance. So this is not a benign impact on quality of life. Grade 3 means you need a feeding tube. So you're unable to swallow food at all. So stomatitis is a significant adverse event and something that we really ask patients and follow very closely. There's a lot of interventions trying to figure out ways to minimize or reduce that toxicity, as well as new agents being developed that are, again, PSMA radioligand therapies, but ones that have less affinity for the salivary glands, which are very high expressors of PSMA. When we look at some of the other secondary endpoints with Pluvicto, we see, not surprisingly, that there is improvement in terms of quality of life scores, as well as the brief pain index as well. So I think, again, appropriate for it to be FDA approved. However, I think it's very important that we moderate expectations for our patients. Now, one of the other, I think, very important studies, and kudos to Dr. Hoffman and others at the Peter Mac in Australia, are trying to understand, who are the patients who will most benefit from these types of PSMA radioligand therapies. Importantly, they did a study where patients with progressive mCRPC after docetaxel, gallium PSMA positive on their PET scans, and then they also did FDG PET scans as well to see if they could identify maybe neuroendocrine cancers that were higher in terms of FDG avidity. Patients were randomized to receive either cabazitaxel at 20 milligrams per meter squared or PSMA lutetium, with primary endpoints of PSA response rate and secondary endpoints of PFS and OS. So this was a randomized phase 2 trial. And interestingly, what they saw was that in terms of PSA response rate with cabazitaxel here, that we saw a PSA response rate of 37% versus 66% over here with the PSMA lutetium. When we look at RPFS rate, what we see is that, so that when we look at RPFS, what we see is that the percent of patients without progression at 12 months was, we had 3 versus 5%. So the curves actually crossed when we look at progression-free survival of cabazitaxel versus a PSMA lutetium conjugate. But at the same time, when we look at PFS, again, at the median, lutetium PSMA did delay progression compared to cabazitaxel. When we look at what was described as deterioration-free survival, so other symptoms that might cause them to come off of therapy, that the lutetium PSMA was superior, at least to some degree. And safety and tolerability, that they did seem to have at least a better tolerability in some regard. But again, when you look here, fatigue, very similar between the two, pain, very similar, dry mouth, 60% of patients receiving lutetium PSMA versus 21% with Pluvicto, or with cabazitaxel, excuse me. However, what was more surprising was that there was no difference in survival. So very different mechanisms of action, and there were differences in both PSA and radiographic response rate, and even some differences in PSA or in terms of pain scores. However, survival was not different. So with the challenges that we've all had in terms of being able to get Pluvicto for our patients, this is actually some data that I used and discussed very closely with my patients of the reasons why cabazitaxel, at least from a survival perspective, was at least as good. Obviously, I want more tools in my toolbox. I want to be able to give more therapies with the hope that sequential therapy will improve outcomes. But again, we don't have a card-like trial with PSMA and chemotherapy at this time. But again, other things that we do need in the future is to study sequencing options. In terms of other biomarkers that Dr. Hoffman and others were able to glean from this, was that patients who had a higher whole body SUV mean were those that had the best clinical outcomes. So I think very impressive, though I think for most centers, this is not reported by our nuclear medicine physicians. It's not automated, it's more difficult than it sounds in terms of getting that data, but other things that will hopefully come down the pipeline. And this finding was also confirmed in the VISION trial as well in terms of whole body SUV mean, with those with the highest, in this situation, had a median RPFS of 14 months compared to 6 months for those with the lowest. So to summarize, this is a lot that I threw at you here. I apologize. However, there's a lot of, I think, really important critical data that we can glean from more intensive molecular analysis of metastatic CRPC that really does make an impact in terms of identifying patients who are more likely to benefit from what is a vast array of systemic therapies. And if we do a good job of it, we'll find ways to sequence these different therapies. I'm excited about our opportunities in terms of differential sequencing, going from therapies, so going across different classes of therapies. And is there even the potential that one class of therapy, for example, if I have a patient who's progressed on an AR pathway inhibitor, we give a chemotherapy or some other mechanism of action targeted agent, could we potentially eliminate that resistant clone and maybe even resensitize our patients to another AR pathway inhibitor? We have some small early data in that space that's coming out. I'm excited for future trials really to help us better understand how can we rationally, not just rationally combine therapies, but also rationally sequence therapies for our patients. It's always critical to evaluate for neuroendocrine or small cell cancer. Do not rely on PSA for that determination. If your patient says something's different, I don't feel well, but the PSA is stable or low, image, get scans, do a biopsy if you see unexplained sites of progression, and evaluate for NEPC. Platinum doublet chemotherapy does improve survival, and with appropriate dose reductions and supportive care, it can actually be quite tolerable. Now, in terms of the future, I'm a medical oncologist. Hope springs eternal. We have had more therapies developed in the last 5 years than the 30 years before that. And we have more agents in development, whether that's other PARP inhibitor combinations, bispecific antibodies, antibody-drug conjugates, other radioligand therapies or theragnostics. I think the opportunities and what's coming in the future, many of those in clinical trials right now, phase 1, phase 2, and some going to phase 3. I think we have many opportunities, and it's a very exciting time in prostate cancer research. So with that, thank you for your time and attention.